Thank you, Krunal and the team, for inviting me. Uh, I will talk on this common topic, but I probably will be introducing you a few new tips in the management. And when you are just going through my talk, I may be going through a large number of slides. Don't worry about the slides that I'm passing very fast. You don't try to read them. The important ones I'll be slow. And then I'm giving this presentation to Krunal. I have no problem about anybody. All these are mine, so there's no copyright issue as such. And it is free for you to share it, but the whole idea is take the message that I'm going to give so that you will save life with dengue. And I don't mind anybody sharing it. Okay, so I'm just going to tell you about my insights from my bedside. I live in I have a separate dengue center, which she talked about, near in Negombo. In this center, which is, I live within 5 minutes of it, 5 minutes of walking distance from it, for the last, say, 13, 14 years. So therefore, I see these patients morning, night necessarily, and also I could walk to see the patients anytime within 5 minutes, which I've been doing for the last more than a decade. And also there is one private hospital where I admit patients. That is also within 5 minutes. So the unique ability I have had to follow these patients is to go to their bedside within 5 minutes from my home, anytime during the day, and that's what I am going to tell you. Now, the Center for Clinical Management, which I said, is this, and I've looked after dengue patients. Though I'm a pediatrician, I see, in fact, currently I see more adult dengue patients than pediatric dengue patients. I see patients of all ages. The age range is transplacentally acquired dengue in a 1-day-old baby to a 100-year-old grandma. I have a database of 16,000 patients where we looked at more than 100 variables on dengue. That's probably the biggest database on dengue that we have in the world. And this is what a dengue epidemic is like. In the 2017 dengue epidemic, this is the male ward. These standing people are patients because they don't have enough beds. And this is the female ward. And this is the children's ward where 3 DHF patients who are leaking have to share one bed. And in my journey, I was an intern in 1989, where the dengue mortality was 9.8% or almost 10%. And today we've seen almost 100 to 200-fold reduction in dengue. I think dengue is a zero mortality disease, and very much so in the pediatric age group, because mortality is the morbidity, so comorbidities are less. Now I'm just going to tell you how to look at zero mortality. One of the key things that I want to tell you is, you are reading many things about dengue, and I just want you to adopt only the WHO zero classification of 1975, which transformed into 2011, and not the famous the second classification. So in this classification, the most important thing is that it differentiates dengue fever and dengue hemorrhagic fever as 2 different entities. And DHF is not badly managed dengue fever. And this is that classification. These are the 2 people who were mainly, they are my mentors as well, Professor Suchitra and Professor Halsted. I try to show them in every presentation. I learned most of my dengue from them. This is the natural history of dengue. It's asymptomatic in many and so on. And then you have this important group where you have dengue hemorrhagic fever. They have what you call plasma leakage. Occasionally you will have some atypical or expanded dengue, which may be due to co-infections or even comorbidities. But that's a very small percentage. We cannot put everybody into this classification, but it doesn't mean that this classification of DF, DHF is bad. So remember that 95% of dengue deaths occur in the dengue hemorrhagic fever group where you have plasma leakage. So that's the key messages, one of the key things that we need to understand managing dengue. This has three phases: the dengue hemorrhagic fever, where you have a febrile phase, a leaking phase, and a convalescent phase. The difference of dengue fever is that has no leaking phase. That's the case for majority of patients. Now, in the dengue hemorrhagic fever or the leaking syndrome, there is a transient plasma leakage through the capillary walls only in the pleural and the peritoneal cavities. And this does not last for more than 48 hours. This is observed over decades. The volume loss during this leaking period from the intravascular compartment can lead to shock and organ hyperperfusion. If you see a dengue patient who has a swollen body, periorbital puffiness, or detect pericardial effusions, that's not natural dengue. That's all due to giving a lot of fluid. So DHF is largely a predictably treatable disease. That is what I want to tell you. If you know, this classification of 2009 is the one that I'm discouraging you to use, because this does not identify DF and DHF as two different entities. So largely, remember, large majority of dengue deaths occur inside DHF, and managing DHF better is the way to reduce deaths. DHF is not badly managed DF, but in the DHF you get dengue shock syndrome. Dengue shock occurs when the dengue hemorrhagic fever, initial dengue hemorrhagic fever, is not managed well in most cases. So DHF has 1, 2, 3, 4 grades. If you don't manage the grade 1 and 2 well, you will end up with 3 and 4. Now, if you are aiming at zero dengue deaths, one of the other important thing that you have to do is to make a firm, good early diagnosis of dengue. Now, compared to what I talked 10 years back, we know that there is a good way to diagnose dengue now using a dengue illness on antigen test kit. People will say there is an issue about sensitivity, specificity, but we'll leave it long that we should, the laboratory, the methods are so good that we could actually fairly accurately diagnose dengue early. If you do this test using a good test kit at the end of 24 hours, you get almost more than 95% chances of detecting dengue. So do that. I don't think we can get a test for any other disease like that to make a good diagnosis. From about day 5, you may be able to see antibodies. Remember, the antibodies can come from past infection as well as present infection, but they become detectable only if there is a new infection. Therefore, any IgG or IgM positive, or whether they are both positive, that all suggests that this patient has got an infection now. Just don't miss out, say if the IgG becomes positive, IgM is negative, don't say this is past infection and pass it on. It is acute dengue, right? Now, to do a full blood count, it is not good to wait for 3 days as we were practicing earlier if you are to make 0 days, because occasionally a leaking can start as early as day 2 and the patient can be dead in day 3. This is one such example. Now, once you do the first full blood count, I would say as soon as you make a diagnosis of dengue, probably you can take blood for the NS1 and full blood count at the same time. Maybe the CRP also, just to see if somebody comes with fever. And then when you see the full blood count, when to repeat. When to repeat the first one, that's the, you probably will have to do a second one the next day, whatever it is. Because sometimes a platelet count of 400,000 might drop to 200,000 the next day, which is more important than a 200,000 drop into 180,000 the second day, because it is a big drop. So just because you see a high platelet count, don't wait for another 2-3 days to repeat it, right? So just do a second one. Look at the rate of dropping, right? Sometimes you have to do it more than once a day. Then once you know that this is dengue, and then you try to differentiate DF from DHF as early as possible. Diagnose DHF early. To do that, there are various things in the past, warning signs, rapid drop in the platelet count. Sometimes you get a reversal of the neutrophils to lymphocytes. Liver tenderness is a useful thing. If you see a maculopapular rash, they are mostly DF. But the classification that I ask you not to use, it gives various warning signs, but they're generally useless. And some of them are, by the time they're not warning signs, they are already, if you have clinical accumulation of fluid and shock, means it's not warning, you have gone too far. Now, to diagnose DHS, the best is to do a bedside ultrasound. This is not rocket science. It's one of the simplest tests. Unlike even a full blood count, you don't even need a reagent. You can keep reusing it. It takes only 5 minutes, faster than any test. And when to do the ultrasound, if you get a full blood count and the platelet count is 100,000 or close to 100,000, then do a ultrasound scan. Even if it is not high, if the first day's platelet count is 400,000, second day is 200,000, that's a rapid drop. Then occasionally a patient might leak at a platelet count of 150,000. So when you see a rapid drop, do an ultrasound scan then and there. But you will have to keep repeating it. I created this form, the ultrasound form, so that the radiologist or whoever is doing it will not complain that they will be sued for missing a tumor or something. This is just simple gallbladder edema, pericholecystic fluid, hepatorenal fluid, pelvic fluid, right pleural effusion. Those are the things that you have to just specifically look for. If these things are there or not, then you can see whether the leaking is there or not. So if this form is blank, this patient is still a DF, not a leaking patient. So if you have the ultrasound negative, either you are a dengue fever or a dengue fever who has not started leaking yet. I started using this in 2012. Now this is, and then we used it in large number of patients during epidemics. And now every ward has dengue in Sri Lanka. This is standard. Routine ultrasound is standard for all patients whose platelet count are nearing 100,000. So we have to get a system organized to make limited bedside ultrasound routine and standard. I'm sure it's very much possible in India. Then, because earlier we only looked at the hematocrit rise. The hematocrit rise is a useful thing, but it's not good enough for 0 days. You can sometimes a patient will be dehydrated and the hematocrit will rise, or a patient will bleed and the hematocrit will not rise. Therefore, it's not good enough for 0 mortality. Now, once leaking is confirmed, you really need to look at the hematocrit. You have to repeat the hematocrit few times to see what exactly is happening. It depends on the clinical condition of the patient. You don't have to do it very many times. Remember, HB is 1/3 of the hematocrit. This is Professor Scott Halstead again. He's one of those people who popularized the use of bedside hematocrit those days. And you have to get this in your system if you want to see 0 mortality. Then there's a famous thing called reshock, which people talk about. Reshock is always iatrogenic. Reshock is always, if you are not managing well, only the patient will have reshock. Otherwise, a dengue patient cannot have reshock. And by monitoring pulse pressure, blood pressure, heart rate, hematocrit, you should be able to, and urine output, you should be able to avoid it. Once dengue hemorrhagic fever is identified early, avoiding the first shock is so easy. All what you really need to do is to try and see that you maintain a pulse pressure. Just do not go behind the blood pressure, the systolic diastolic. Look at the pulse pressure difference. It has to be more than 30. It is 30 from neonate to the old 100-year-old. The pulse pressure is above 30. It has to be above 30 for good perfusion to avoid organ hyperperfusion. Occasionally, there may be somebody whose pulse pressure is 22, 27, 28, but that is less than 0.5%. Now, if you want to measure blood pressure properly like that, you probably have to use a monitor, a multi-para monitor, not manual. So, for your important patients, try to use a monitor, right? If you are in a situation where you are in doubt, if you have 2 monitors showing something different to what you manually get, believe the monitor. So try to use a multi-para monitor for your important patients. And giving fluids, what is the aim? You need to maintain a pulse pressure above 30 all the time, not 20, because below 20 is shock. At that time, organ hyperperfusion, multi-organ failure starts. You should not avoid it happening. And when your pulse pressure drops to between 25 to 30 to 25, you should just be worried about and you should plan to intervene. If it is less than 25, you have to intervene. And then tachycardia. Tachycardia is one of the most important things. If you really want to, if you go through dengue death reviews, you will find most of these patients had some tachycardia which was ignored before. So tachycardia is the most worrying clinical situation in a dengue patient. It could be due to fever, excitement, hypocalcemia, but the most important bleeding. So if you see tachycardia, don't ignore, just sort it out. Control the fever. Is the tachycardia disproportionate to the fever? The most important thing is you will see a patient who's having 101 fever with a heart rate of 100. You will say 100, 105. This is due to fever. But remember, if you go to the pulse chart, you will see yesterday the patient had a fever of 101, but the heart rate was only 85. Now today it is 105 for the same fever. It is not proper, so that is tachycardia. Just don't ignore it saying that it is tachycardia. So check for fluids, ask whether there is the patient is thirsty, do a capillary PCV, that if you have tachycardia going, give some calcium, you give IV calcium, take a first dose of IV calcium while sending a sample, check for bleeding. You will do the stool for, send a sample for stool for occult blood. Sometimes the first sample will come as negative. After 2 days, the sample will come as negative. GI is one place where you will have bleeding without anybody noticing. Because your PCV, everything else will be okay. The pulse pressure is good. Still, this patient has started bleeding. You have to act early. Get rid of the blood transfusion. So when you see a tachycardia not sorting out, order blood and keep it ready. Get ready with, use tranexamic acid. Even if it is empirically, tranexamic acid is a great thing that has helped to stop or reduce bleeding. Use oxygen in the face mask, because when you give face mask oxygen, the bodies work up when the tachycardia will get less, it becomes easy. Then use a judicial fluid regime to maintain the key parameters. That is what I am importantly going to tell you. The main cause of death in dengue hemorrhagic fever are prolonged shock, fluid overload, and massive bleeding. And when you are giving fluid, if you want to do a good regime, you need to count the fluid from the start. Count the fluid from the start, then only that you will avoid the fluid overload, which is one of the major causes of death in dengue, especially in the hospitals. Because dengue patients hardly die at home these days. They die in hospital because of sometimes as a result of coming to hospital, right? Because of the treatment. So counting, monitoring is an important thing. Also, you need to know the duration, right? If you see the platelets rising, you know that the leaking is over. If you are sure that it is not a lab error, but the platelets have started rising, don't say that this patient is continuing to leak. It is still only 36 hours. Therefore, the patient is leaking for 48 hours, and go on treating the patient as for a leak. These are different fluid regimes used world over. But this is traditionally people use 3 to 10 ml per kg of fluid, mostly 3 ml per kg per hour in an ascending and descending pattern. Now, what I am going to tell you is the fluid regime that will work more easily than this ascending, descending, dancing fluid regime. What they say is that the dengue will have leaking which is going on, will gradually increase and gradually go down. Therefore, you have to match the leaking. Therefore, you have to gradually increase the fluid and gradually reduce it. That is the thinking. But I am telling you that the leaking volume, rate, sizes, effusions, they does not seem to be completely independent of the rates of fluid you give. You give more fluid, you will leak more. You give less fluid, you will leak less. It is not independent of the fluid that you give. So you can actually control the leaking. And if you give more fluid, you will get bigger effusions and fluid overload. If you give too little fluid, you will get shock and hyperperfusion. This is a fluid quota. I told you that I am sharing this so you can have it. This is a fluid quota which you have to remember. Main resistance 5% is what you need to use. The ideal body weight is the 50th centile. So you calculate fluid for the ideal body weight. Actual body weight, if the weight is less than the ideal body weight. Then adjusted body weight, if the patient is big and heavy, this is the formula for adjusted body weight. Then you calculate what is the fluid quota is. Now the duration of leaking never exceed 48 hours. It can be as short as 6 to 8 hours, mostly 24 to 48 hours. If the duration is less, the amount of fluid that you will need is less than the fluid quota. When you see the platelets white cell count, you will initially see it dropping and it will start rising. But when you see the platelet count start rising, your leaking is over. So 99.9% of the time, when the 2 consecutive platelet counts rise, you have to say that the leaking is over. The leaking may be as short as 6 hours or maybe as long as 48 hours. So when you're following a dengue patient, after 24 hours of noticing leaking, just see whether the patient is still leaking or whether the patient is has stopped leaking. Because have a look before you proceed further, and try to, if you are using for 24 hours, try to use only half the fluid for the first 24 hours that you calculated. My fluid regime is this. This is the one that I really want you to know and remember and practice. That is 1.5 ml per is the total fluid that we give. We give 0.5 ml per kg IV and 1 ml per kg oral for all children, say above 10 kilos or above about 1 year. The ones who are smaller and the infants, you can use 2 ml, that is 1 ml IV and 1 ml oral, right? And give this fluid and try to maintain a pulse pressure, check and see there are no tachycardia, pulse pressure is about 30, and you have urine output more than 0.5 ml per kg per hour, good if it is at least more than 0.7 ml. And if the patient is thirsty, forget about, you just measure what you give, but give the fluid that the patient will need to control the thirst. You see, so this is what you call the flat rate fluid. So what I am advocating is to give the fluid at a flat rate of 1.5 ml per kg from the beginning to end. If you have any problem, give an intermittent bolus rather than gradually increasing it to 1.5, 2, 2.5, 3 and so on, right? This has worked. We have a big database of 16,000 patients whom we have used this, and it works perfectly. And so the way I give is 1.5 ml per kg per hour, which is 0.5 ml IV, 1 oral during the daytime. From 10 o'clock to morning, because they can't be drinking, I give 1.2 ml total, right? Total. If thirsty anytime, I could give 2 ml per kg oral for a maximum of 3 times. Maximum of 3 times within 24 hours. If you still either the urine output is low or there is tachycardia or whatever, then you can give a bolus. The bolus could be either a colloid dextran 40 or normal saline in 5% dextrose. A full bolus is considered 10 ml per kg given over 1 hour. A half bolus is 5 ml per kg, still given at 10 ml per kg per hour rate, but only for 30 minutes. So that's a half bolus, that's a full bolus. And this is what is published in the infectious disease journal about my treating. This won the best paper prize for using flat rate fluid. And in this we showed 400 dengue hemorrhagic fever patients who used this regime, and nearly 2/3 of them, 66%, could just end the leaking period just at a flat rate of 1.5 ml. It is like a cruise control on a highway. That's all. The patient will leak and finish and end, and you don't have to do anything. And only just normal saline. And this is what it is. This is the regime compared to the traditional regime of ascending descending. And so when the platelet count is more than 150,000, you can just give fluid the way they can just take any amount of fluid, just maintain normal urine output. When it is coming towards 100,000, you restrict it. These are the fluids that you could use: saline, Hartmann, dextran, blood, sometimes some blood products. The calculate now, when you are giving the fluid, the important thing that I am going to introduce now is when you are giving the fluid, calculate the fluid on a time scale. That if you have a fluid regime, you should not use more than half of it over 24-hour period. That is, you calculate, you give it while checking. Try not to exceed the flight volume. I introduced this term called WATS, volume over time scale. That is, whether you are finishing, you have got a fluid to manage this dengue patient, try to use only part of it. It's like if you get a salary, you finish everything, you try to manage the whole month by using maybe 60-70% of the salary. So this is a formula. You can take a screenshot, or you will get this. I said that this can be shared. Use this formula and see what this is doing is just to see whether the patient is, how much of the fluid is he managing with. Normally, though they have a fluid regime, most patients will need only 70 to 80% of the fluid. In general, best is to keep the watts at 60 to 80%. Decide on an intervention looking at these watts, right? Whether you give a colloid or a crystalloid will be decided on the watts. More fluids, if you are given more fluid, suppose you are given, your watts is 100%, means you are given a lot of fluid, and you are given a lot of fluid, but the urine output is not good. Now don't give any more fluid, you just give a small test dose of furosemide. You can give furosemide to a dengue patient even at the beginning and any time during the 48 hours. Earlier people thought it should not be tried when the leaking is at the peak. There's nothing like that. You have already used enough fluid. Then the next is not to increase more fluid. Try a small dose of furosemide. And in this study we showed that 2/3 needed only 1.5 and 75% 1.5 plus just one more another crystalloid bolus. Only 10% needed crystalloid and colloid both, as that 90% could just go through, and only 3 to 4% needed single colloid bolus. So this is the fluid regime. If in our setup, if a patient has come to us with a platelet count of more than 100,000, using this regime to date from 2013, we maintain zero mortality. We haven't had a single death. This is, I try to skip through this. This is just an example of how to use this. So the few key messages that I want some question time. Remember, any fever could be dengue, and NS1 on day 1 to 2 is the probably best time to do it. Serial ultrasound you should do to diagnose leaking, and bedside hematocrit is useful for monitor leaking. Keep the pulse pressure above 30 all the time. Never ignore tachycardia. Maintain urine output at 0.5 to 1 ml. If possible, 0.7 ml most of the time. Intervene if the urine output is less than 0.5. Keep counting the fluid you are giving to avoid prolonged shock and fluid overload. When consecutive platelet counts are naturally rising, leaking is over. So don't keep giving fluid as for leaking. Leaking can occur as early as day 2 or as late as day 7. And leaking may be as short as 6 hours or as long as 48 hours. There are new virulent viruses, genetic ethnic factors. We are all talking about new things coming, new serotype. But remember, the disease is changed by the way we manage the patient. Thank you.